All right, let's get into it. Today, we are tackling an absolute classic, a high-stakes scenario you are basically guaranteed to see in your OSCEs, the upper GI bleed. We're going to break this down step by step, history, exam, management plan, so you can walk into that station feeling confident and ready to crush it. Let's do this. So picture this. These are the first words your patient says to you. It immediately tells you how high the stakes are. This isn't just some academic exercise, right? You're managing a terrified person who's in a potentially life-threatening situation. Your calm, structured approach here is absolutely everything. So, to nail this, we're going to follow this 6-part plan. We'll start with the case, dig for clues in the history, figure out what's causing it, then make a solid action plan. After that, we'll cover the emergency stabilization and finally wrap up with the long-term treatment. Okay, the timer starts now. You've got 8 minutes. Your patient is Lisa, she's 45, and she's in the emergency department. Your job is to figure out what's going on and what you're going to do about it fast. Time is absolutely critical here. So let's zero in on the description of that vomit. Coffee ground vomit? What does that tell you? It means the blood's been sitting in stomach acid for a bit, right? So it's probably a slower bleed. But then she says it's turned into bright red blood. That's hematemesis. And folks, that is a huge red flag. It means the bleeding is active and happening right now. And those black tarry stools, classic melena, digested blood. You put those together and you've got yourself a serious upper GI bleed. All right, now we shift gears into detective mode. We're gathering information. Being systematic here isn't just good medicine. It's how you show the examiner you know what you're doing. Every single question has to have a purpose. Let's break this down, okay? You need to get a sense of how much blood she's lost. Asking for an estimate in cups or teaspoons really helps. And you've got to ask about other symptoms, like feeling dizzy or short of breath. Those are flashing red lights for major blood loss and hemodynamic instability. But honestly, the real game changer in this history is often the medication and social history. You have to ask about NSAIDs, anticoagulants, alcohol, and smoking. It's non-negotiable. Now, this little exchange, it's gold. It shows a really important skill. See how the doctor is direct? You have to be in an emergency. But the tone isn't judgmental. When you're asking these sensitive questions, that non-accusatory approach is how you get an honest answer. Trust me, the examiners are watching for that professional empathy. So you've got your clues. Now it's time to put on your detective hat and piece it all together. The history you just took lets you build a list of the likely culprits, starting with the most obvious one. Okay, let's hit pause for a second. Let's really think about this. Lisa said she takes painkillers all the time for her joint pain. In your head, what diagnosis should be screaming at you right now? This is really the heart of the case. And there you have it. These are your prime suspects. You know, chronic NSAID use is a huge risk factor. Why? Because those drugs block the enzymes that make the protective lining in the stomach. That can lead straight to peptic ulcer disease, or maybe something more widespread like gastritis, or even smaller scrapes called erosions. For Lisa, these have got to be at the very top of your list. And here's a great way to organize your thinking. On one side, you've got your common causes, with peptic ulcer disease leading the pack. But on the other side, you've got less common things that you just can't afford to miss, like a Mallory-Weiss tear. That's a rip in the esophagus from really forceful vomiting. Or varices, which are these swollen veins you see in really bad liver disease. You have to keep these in the back of your mind. Now, if you really want to impress the examiner, you need to know the difference between the two main types of peptic ulcers. The classic tell is their relationship to food. Gastric ulcer pain usually gets worse when you eat because the food just irritates it. Duodenal ulcer pain, it can actually get better with food because the food acts like a buffer against the acid. Kind of interesting, right? Okay, history's done. Now you have to tell the examiner exactly what you do next. This means a focused physical exam and ordering the right first set of tests. You need to just run through this checklist, starting with the absolute #1 priority, ABCs. You're checking to see if she's hemodynamically unstable. Is her heart rate up? Is her blood pressure down? Those are signs of shock. Then, the abdominal exam is crucial. A little tenderness in the upper abdomen might point to an ulcer, but a rigid, board-like belly, that's a massive red flag for a perforation, a hole, and that's a surgical emergency. So as you're examining her, you're also rattling off the test you want. A complete blood count gives you that baseline hemoglobin to see how much blood she's lost. Urea is really key, not just for kidney function, but because it can go up when you digest a bunch of blood, and it's also part of a risk score we'll talk about. And, so important, get a group and save or cross-match. This patient might need blood, and she might need it like yesterday. Okay, this is where you really earn your stripes. This is the part that saves lives. The patient is actively bleeding. Your focus has to shift completely. Resuscitation always comes before diagnosis. You have to stabilize the patient before you can even think about fixing the root problem. So, what's our mantra in this situation? Say it with me. 2 large bore IVs, always. We need massive access for fluids and potentially blood, and we need it now. Start pumping in those crystalloids to get that blood pressure up. You have to be thinking about a transfusion if she's unstable or that hemoglobin drops below 7 or pulling the trigger. But you know what might be the most important step here? Calling for help. You have to say it out loud to the examiner. I'm calling for my senior and consulting GI. That shows you're safe, you know your limits, and you're a team player. Huge points right there. Now, to get a bit more formal about the risk, we use scoring systems. The Glasgow-Blochford score is the one we use before an endoscopy. It helps us predict who needs an urgent intervention, like a transfusion or surgery. And it's all based on these simple clinical signs and lab results you already have. And you know what really shows the power of this score? The number 0. If a patient scores a 0 on the Glasgow-Blochford, they're considered very low risk. So low, in fact, that you could potentially manage them as an outpatient. Think about how huge that is for the healthcare system. It helps us avoid unnecessary admissions. Now, Lisa, with her active bleeding, and Melina, she's going to score way higher, confirming she absolutely needs to be admitted for urgent intervention. Now, it's super important not to get the GBS mixed up with the Rockall score. The Rockall score is what we use after the endoscopy. Why? Because it actually includes findings from the scope, like what the ulcer looks like or if there's a visible bleeding vessel. So it's less about the immediate what do we do now, and more about predicting long-term outcomes, like the risk of rebleeding or even mortality. So the patient is stabilized, you've figured out their risk level. Once they're stable enough, we can finally move on to definitive treatment. And that starts with having a really important conversation with them about the plan and getting their informed consent, especially for an urgent procedure like an endoscopy. Med-wise, the absolute cornerstone of treatment is a high-dose IV proton pump inhibitor, a PPI. What this does is drastically cut down on stomach acid. That creates a much better environment for clots to form over the bleeding site and stay put. And you start this right away, even before they go for the endoscopy. And finally, you've got to document everything. This is a non-negotiable part of the station. Just use a simple, structured template like this. HPI is your history, PMH is past medical history, and so on. Your assessment and plan, your A/P, needs a really clear, concise summary like this one. Acute upper GI bleed secondary to likely peptic ulcer disease from NSAIDs. In one sentence, it tells the whole story. And we'll end on this thought. Because stopping the bleed, that's only half the job. The real art of medicine is making sure this doesn't happen again. Lisa's joint pain isn't just going to vanish. So what's your plan for that? How do you counsel her? We're talking about safer pain meds, maybe non-drug options, and if she has to take an NSAID, it's the lowest dose for the shortest time, always with a stomach-protecting drug like a PPI. Answering that question, that's what separates a good candidate from a great one.